Hello, everyone. Welcome to Spine Anatomy. The stunning architecture of the spine plays an extremely important role in our bodies as it supports and distributes the weight of the upper form and provides posture and allows for movement, all while protecting the graceful tissues of the spinal cord. So, its curvy nature evolved to help us leverage the limbs, giving us the unique distinction as bipedal mammals. While we're often asked by our teachers yoga teachers to straighten our spines, we have these elegant and meaningful curves for a reason, and they should be supported and maintained whenever possible. So there are 24 individual articulating vertebrae, as well as the fused bones of the sacrum and coccyx, which make up this great column. And these bones can be separated into different regions and curves. And while most vertebrae have a similar structure, each region of the spine has slight anomalies, enough to make a big difference to the type of movement allowed in each region. So at the top of our spine, we have 7 cervical vertebrae, and we have 12 thoracic vertebrae, followed by 5 lumbar vertebrae, and 4 to 5 fused sacral vertebrae, and then about 3 to 5 coccygeal vertebrae, the tailbone. So in the adult spine, we can acknowledge 4 different distinct curves. So at the cervical spine, we have a lordotic or a concave curve. So meaning that this is concave. Now in the thoracic spine, we have kyphotic or convex. So notice how it goes down. And then in the lumbar spine, we have again a lordotic or a concave curvature. Finishing at the sacral coccygeal process, we have a kyphotic or a convex curve. So you hear us say a lot of forward tilt about the pelvis or lordosis or a kyphotic pelvis. But the reality is that although the terms loosely refers to an exaggeration, um, we have these natural curves, and again, we're meant to move and protect our spine to keep these curves because they're there for a purpose. Now, the lateral and rotational deviation of the spine is called scoliosis. And so people with scoliosis will typically have a spine that looks more like this. This is an S-shaped scoliosis. Or it can also look sideways, that it's misaligned from the top down. So those people with scoliosis have very unique anatomy, which will take a much more individual study to address in a yoga practice. And there are methodologies and techniques in yoga for people with scoliosis. This is just not something that we cover in this teacher training. So the lumbar curve is unique to humans and allows us to have the leverage, shock absorption, and balance to ambulate on our feet. And so you've ever seen a trained chimp that's taught to walk upright in an effort to look more human? If you've noticed, they throw their long arms overhead and then slightly behind them to create a mock lumbar curve. This allows them to temporarily walk upright. So most individual vertebrae will have similar appearance. Anteriorly, they have a vertebral body that supports and translates much of the weight. So this is the anterior part of the vertebral body, and it supports and translates most of the weight. Now, posteriorly, they have a beak-like projection called the spinous process. And so, and two lateral projections called the transverse processes. So if we were to undo this, this would be the spinous process, and then the projections are called the transverse processes, are the two lateral projections. So if we look at it sideways, anything that's pointy on a bone, like these processes, is a great place for muscle and ligament attachment. So these three projections create a vertebral arch, and the negative space is called the vertebral foramen. So when you line up all the vertebral foramen, you have the vertebral canal in which the spinal cord descends. I'm going to show you how the spinal cord is set in between all of these vertebrae. So if we add some of the nervous aspects of our body, you can see in the middle is the spinal cord, the central nervous system. And notice how all of these nerve endings are moving from the spinal cord and out through out onto the limb. So this is important, guys, because if we are in our yoga practice, we're not taking care of our spine and our posture. We have the tendency to either squeeze into our vertebrae, and the danger is to pinch any of these nerves that will create either numbness or pain in any part of the body. Specifically, notice here on the cervical spine region, all of those nerve endings go onto the shoulder and onto the hand. So people that experience numbness of their limbs possibly have some sort of impingement at the cervical spine. All right, so going back into our spine, when the vertebral arch meets the body of the vertebrae, you have two small facets. And most vertebrae will articulate with their neighbors at three joints, the two facets and the vertebral bodies. You will have us, I'll show you something in a video in a very short while about how these facets interact with each other. So they rest upon each other like a stool, and they, when properly aligned, they provide strength and stability to the column. So we'll go closer. Oh, this is a good angle. So we're talking about the facets right here. In between all but the first two vertebrae rests a special piece of fibrocartilage called the intervertebral disc. And so this disc is often compared to a stale jelly donut. Let's look at it so you can see how it, all right, make this guy longer and add a layer of connective tissue. All right, this is what we're talking about. This disc is often compared to a donut, and it has a tough fibrous shell called the annulus fibrosus and a jelly-like center called the nucleus pulposus. So these donuts help to distribute the weight in the intervertebral joint and act as shock absorbers. So if you imagine pressing down on the front of the anterior of the jelly donut, like in flexion of the spine, the jelly would be smushed posteriorly or towards the back, and pressing down on the posterior is as an extension of the spine. The jelly will be smushed anteriorly. So when we twist and rotate our spine, the two bodies of the vertebra will move closer together, and the jelly will be squished in all directions. Important. Specifically when we're doing anything that is meant to be a rotation in a twisting triangle and seated spine twist, standing separate leg twist, all of this require the longest spine available to protect the spine from squishing the, the, the disc in between the vertebrae. Let me show you an example of the squishing action.
Nerve roots extend from the spinal cord through the openings of each side of the cervical vertebrae. Intervertebral discs located between the vertebrae prevent friction and allow for smooth movement between vertebrae. A herniated disc may occur due to degeneration of the disc or from rupture of the disc secondary to trauma. The herniated disc compresses the spinal nerve root against the vertebra. This results in pain, numbness, or weakness along the involved arm or hand. Lumbar sprain is caused by stretching or tearing the tough ligaments that connect adjacent lumbar vertebrae. This can occur from a single unexpected load, such as improper lifting, or can occur from gradual overuse. Symptoms include back pain, stiffness, and decreased range of motion. Lordosis is an excess inward curvature of the spine, giving a swayback appearance. Lordosis can affect persons of any age. Certain conditions can contribute to this condition, including obesity and osteoporosis. Scoliosis is a back condition which causes the spine to curve to the left or right side. Lumbar scoliosis occurs in the lower part of the spine, where a three-dimensional deformity of the vertebral column results in abnormal curvature of the spine. Nerve roots extend from the spinal cord through openings on each vertebra. Intervertebral discs located between the vertebrae prevent friction and allow for smooth movement of the vertebrae. Spinal stenosis is a condition caused by disc degeneration in the cervical spine. This results in the formation of bone spurs, which cause the narrowing of the spinal canal. The narrowing of this opening causes compression of the spinal cord and nerve roots. Compression of a lumbar nerve root causes motor or sensory deficits in the regions supplied by the affected nerve. Compression of the spinal cord can result in abnormal reflexes, disturbances of balance, and muscle weakness or incoordination.
So the way the discs maintain their health and plumpness is through movement. When we move the spine, the disc will get wrung out, and when we release the movement, the disc drink from the neighboring tissues. This is important, guys, because hydration will directly impact our discs. And so when we are not well hydrated, we have a greater chance of losing a lot of the elasticity the discs have. And also because they're drawing fluid from all the other regions, we are more prone to get injured. And so you might have heard that if you were to measure yourself first thing in the morning, you would be a little bit taller than if you measure yourself before going to bed. And this is because of the pull of gravity on our upright bodies, and it compresses the discs. So as they lose some of the moisture to the surrounding tissues, as we rest, changing the way gravity affects us, the discs get to plump back up. And obviously, as we age through the disc, as we age though, the disc lose much of their own water content and direct blood supply, so leaving them more prone to damage and to strain. Weakening or tearing in the outer shell of the disc can allow the jelly to poke its gelatinous head out, otherwise known as a bulging disc. And it is estimated that between 60 to 70% of the people 35-year-old will have some kind of deterioration, bulging or herniated disc. The good news is that depending on the direction in which it pokes out, you could be completely asymptomatic. Unfortunately, most of the time, the jelly will begin to protrude laterally and posteriorly, and this is where it puts us at risk of pressing into the spinal cord or spinal nerve roots, causing pain, tingling, or numbness along the path which that particular nerve travels. Without surgical intervention, the gel will never snuggle neatly back into the donut and will always be compromised. And so much of the work in physical and yoga therapy is to create more space between the affected vertebrae and to shore them up with the surrounding muscles to help hold that space. Important about our practice is that we are strengthening all of our stabilization for specifically for keeping the spine in good health. So I'm going to add a layer of muscle to our model. And you can see the processes that support all the ligaments, the tendons, the connective tissue. And if we add more layers to that spinal column, noticing how all of this, how well protected it is by layers and layers of muscle. And we'll talk about more of that shortly. Much of the work, like I said, is about keeping the muscles strong and holding space. So observing postural imbalance is also key to help lessen the chance for the discs to irritate the nerves again. While the possibility of injury in all regions of the spine exists because of the weight supported, amount of movement, and postural pitfalls, the lumbar region wins as the most prone to disc injuries. Each region of the spine is unique, and also the mobility of each vertebra is determined by its bony projections or processes, its surroundings, and how things fit together. So we're going to take a look at one section at a time, but keep in mind that the most complex yoga movements involving the spine involve many vertebrae across many regions. Looking at the cervical vertebrae, so there are 7 cervical vertebrae making up the lordotic cervical curve. C1 and C2 are unique. C1 is the Atlas, named after the Greek Titan who held up the celestial sphere. So for us, it would be our heads, articulates with the base of the skull, and it is a big bony ring with no vertebral body or processes. It sits above C2, which is called the axis. So C2 is called the axis, and it has a superiorly projecting phallus called the dens. And this allows the skull and C1 to pivot, as when we are saying no. And then going lower, C3, let's go back into the dens of the axis. Here we go. Inferior articular process of the axis. And then it sits above C3 to C7, which have small vertebral bodies designed by evolution to support the fairly light weight of our head. And C7 is unique because it has a long and prominent spinous process. I'm talking about this. Usually be seen and felt at the base of our necks. And most of the cervical spine flexion and extension takes place at the allanto-occipital joint. This is where our skull meets C1, but it's aided by the other vertebrae in this region. So most of the rotation available in the cervical region will take place in the allantoaxial joint, C1, C2, but like in all movements, is usually facilitated by multiple joints. In the transverse process of every cervical vertebrae, there's a very small foramina or holes in which the special vertebrae arteries will rise. And so Good. Talking about these holes. And so we add some artery into our model. You see where those arteries go in those openings. These are fountains of oxygen-rich blood that feed the brain, and housed in a delicate bony ring, they are not usually put in jeopardy. But in yoga, we have the audacity to stand on our heads, right? And then this headstand is one of the reasons why we don't do headstands, or we don't teach it at our studio. The small vertebral bodies are poorly equipped to support the weight of the entire body like we ask them in a headstand. And so sometimes in practices, we are taught to throw our head way back in an extreme extension or rotate the neck beyond the limits in certain poses. And this is dangerous. It's a dangerous combination of rotation and extension. And all of these actions put the intervertebral disc and vertebral arteries at risk for injury. It doesn't mean that healthy individuals can't do these postures, but the key is that they must employ other intelligence because the structure is not well suited for it. So proper and conservative alignment for the head and the neck must be maintained to keep this mobile and dainty area safe. Additionally, with the use of cell phones, what happens to our necks is that because we're always tilted forward, right, not lying at the jaw back like we teach in mountain pose, that keeps the natural curve of your spine. So I'm talking about this concave or lordosis on our neck. And what's happened when we are how we are designing or training our necks is that we're getting rid of that curvature. So basically we're shifting this back and then creating a straight spine, and that is not healthy for our necks. So the alignment of mountain pose really trains us to keep that lordotic curve safe. Moving on to our thoracic vertebrae. So there are 12 thoracic vertebrae in our spine. And so this 12 vertebrae make up the kyphotic thoracic curve, and they are intermediate in size. And we can look at it anterior, lateral, and posterior. And they get slightly larger to support the increasing weight from the upper form and extremity. The spinous processes in this region project sharply inferior with each vertebrae. Notice this is what we're talking about, right? Those bony projections. This greatly limits the amount of movement allowed in each joint, and most movement will come from a combination of vertebrae rather than just one vertebral joint. Extension will be limited by this process. Is like a beak, right? So what's happened is if you're going into a back bend or an extension of your front body, this bony projection will touch onto the next bony projection. And this space shortens if we are not lifting up out of the waist to create space between each of these joints, which leads into that protrusion of the jelly-like towards the front of the body. And so extension is limited, and rotation and side bending, meaning lateral flexion, will be limited by the ribs. So we have 12 pairs of ribs articulating with the 12 vertebrae. Right, we start from the top. We have the first rib. It connects to the first thoracic vertebrae, and so on and so forth. meaning all of this have this corresponding rib. Now, ribs 1 through 7 are true ribs. So we're talking about ribs 1, 2, 3, 4, 5, 6, and 7. And they articulate directly with the sternum anteriorly via its own road of cartilage called the costal cartilage. So let's rotate so you can see it from the front. Now, ribs 8 to 10 are false ribs. They articulate via a multi-lane costal cartilage highway that merges into one attachments at the sternum. So 8 through 10, 8, 9, and 10. And we're talking about this cartilage, the area underneath. Now this will make a slight difference in mobility to the vertebrae to which they're attached. Now T11 and T12 articulate with ribs 11 and 12. And these are floating ribs, and these ribs don't reach around to attach to the sternum and can be felt easily on the side. So these are the floating ribs. This, because there are no connection of these ribs to the sternum anteriorly, this vertebrae will have much more range compared to their own thoracic brethren. All right, so now looking at the lumbar vertebrae, there are 5 lumbar vertebrae. And they make up the lordotic lumbar curve. They have large vertebral bodies and they are very well suited to support our weight. And so they having this robust, stout spinous processes that don't run into each other quickly means flexion and extension are readily available. So notice how the heads don't have that beak-like protrusion, and so most of our back bending will happen from this part of our backside. Now, as we start to open our clavicle and more of a thoracic body in the front is what gives the impression of really deep back bends. But a lot of the open is happening from the chest and from the shoulders rather than moving from this part of our body. The transverse processes are fairly rectangular and project laterally, preventing a great amount of lateral flexion or side bending and rotation. Let's look at one of each. Lateral, anterior, posterior, inferior. Because of the large range of flexion and extension, the large weight, the support, and the shearing movement of this vertebrae, the articulation between the lower lumbar vertebrae and the lumbar sacral joint is the site of frequent injury. Right here. Now the sacrum is a pyramid-like shaped bone with its apex pointing downward. It is said to be made up about 4 to 5 fused vertebrae, and the sacrum and tailbone are curved convexly, contributing to the kyphotic curve. Out of all the bones, the sacrum has the most variety. Size, shape, articulation, and number of vertebrae all vary from person to person, making a huge difference in mobility and stability of the surrounding joints. Superiorly, the sacrum articulates with the fifth lumbar vertebrae. And in some cases, a person can have an extra lumbar vertebrae and one less sacral vertebrae. And this is usually because the first vertebra of the sacrum is not fully fused. And this is called lumbarization of the sacrum. And in some cases, an individual can have an extra sacral vertebrae and one less lumbar vertebrae, called sacralization of the lumbar region. So laterally, the sacrum articulates with the ilia, or part of the pelvis, at the sacroiliac joints, or the SI joints. And so there's some debate as to whether the sacrum has independent movement from the ilia, or if the sacrum just goes along in this joint. Is limited, as this joint is the fulcrum between the upper body and the legs, and it's meant to be quite strong and stable. Now, the sacrum moving along with the pelvic bowl can be thought as a nodding or nutating. As you tip the pelvic bowl forward as if you were spilling its contents anteriorly, the top of the sacrum moves anteriorly and it nutates. So, and then as you tip the pelvic bowl backwards, spilling this contents posteriorly, the top of the sacrum moves posteriorly or counter nutates. By opposing these actions, often we bring strain and compression into this area, which can cause a lot of dysfunction in this joint.
The sacroiliac joint is formed by the junction of the last part of the spine, the sacrum, with the ilium of the pelvis. The joint consists of a narrow, cartilage-filled space between the two bones connected by strong ligaments. There is not much motion in the sacroiliac joint, which normally has only 4 degrees of rotational movement. However, it is a major weight-bearing joint and, thus, is susceptible to degenerative joint disease, which is the most common type of arthritis in this joint. Symptoms of this condition include lower back pain, buttock pain, back of thigh pain, and knee pain.
Moving on to the coccyx. The word comes from a Greek word meaning cuckoo. This refers to the curved shape of a cuckoo's beak when viewed from the side. The coccyx is considered to be 3 to 5 fused vertebrae that are articulated with the inferior aspect of the sacrum. And while there is a disc in between the sacrum and the coccyx, any movement is extremely limited. The coccyx serves as an important attachment site for the ligaments and many muscles of the pelvic floor. So let's add some of those muscles that connect to the coccyx. Looking at the muscles that support our spine, we have the erector spinae. These are muscles that are actually a large group of deep back muscles that run the length of either side of the spine, very much like railroad tracks. All of these muscles together make up the erector spinae. Fibers of these muscles extend from the occiput, meaning the base of the skull, to the sacrum and ilia, with the attachments to the ribs on each vertebrae. And just like the name indicates, they help support and to hold or support the spine erect. When we bilaterally contract them, they take the spine into an extension, like our back bend in Shalabhasana or on locust pose. And when we stretch them by doing a forward flexion of the spine, like in cat pose, and because of this is such a long group of muscles, it is quite possible to have one area very hypertonic or tight, and another area hypertonic, weak, or underutilized. And a typical postural pitfall um, that I see is a pelvis tucked under in a posterior tilt, and the lumbar and thoracic spine kyphotic. Now, because you have to see our phones, where we're going, the neck will hyperextend the chin and it will jut forward. This causes the erector spinae fibers in the neck to tighten and the thoracolumbar fibers to weaken. Looking at the muscles of our core, which are what support our spine and holding space in the spine. In our core class, we talked about the transversus abdominis, and this is the deepest muscle that supports and integrates our body from the upper and lower extremities. Notice how this core set starts from the bottom of our rib cage, and the fibers are running horizontally, and they go all around and meet at the iliac crest, and then just before the erector spinae muscles. Underneath this is a layer of one muscle called the quadratus lumborum, and we're going to take this quadratus lumborum. So it is a four-sided rectangular muscle, and it attaches to the posterior side of the ilia, meaning the crest, and the 12th rib, and the transverse processes of L1 through L5. And when contracted bilaterally, it helps to extend the lumbar spine. And when contracted unilaterally, it will laterally flex the spine or hike the hip upward. Why is this important, guys? Because when we are not using our transverse abdominis, meaning we're not activating it, or we yet haven't found how to activate our TA, the QL is going to take most of the work of stabilizing your spine. And if your TA is not activated, then it'd be pretty much walking around just like this model right here, right, without the whole support of the corset. And this leads to a strain of the QL and to low back pain. Essential to low back pain, to rehabilitating low back pain, is activating the TA through the core exercises, or a multiple of core exercises that will touch the deepest part of your core. Another important part and why we are doing recruiting blood into our bodies in the fifth step is to allow us to go into our back bends and create a lot of space between the vertebrae. Additionally, if we are not using our TA and we are solely relying on that smaller muscle, which is the QL, it will create another strain into the attachment on our hamstrings. Let's add another layer right here, the connective tissue. Right, all of these attachments will start to move up. Instead of being the attachment right here at the back, the base of the hip, they'll start moving a little bit higher, and so that leads to very tight hamstrings. Other muscles that support our spine and protect our cervical spine are the scalenes. And get them a little bit closer here. It's a group of muscles, again, that run diagonally upward from the top two ribs anteriorly to the transverse processes of the cervical spine. And then by lateral contraction, we produce a flexion of the cervical spine. And working unilaterally as a group, the three scalenes laterally flex the cervical spine. And when the cervical spine is fixed, the scalene's contraction can elevate the first two ribs to assist in inhalation. Right? So that is to say that inhaling creates space between each vertebrae. Starts from the cervical spine, but the effect is that all of the muscles that support the rest of the body give the body more height. The sternocleidomastoid. Let's add another layer. And it's a group of muscles again. It's sometimes just referred as the SCM and refers to the prominent and visible strap-like muscles on the neck, originating from both the sternum and the clavicle, and they attach to the mastoid process, bumps on your skull that you can feel behind the bottom of your ears. When contracted bilaterally, they help to flex the cervical spine, and contraction unilaterally will create both a lateral flexion and a rotation to the opposite side of the cervical spine. And when the cervical spinae is fixed, the SCM helps to leave the sternum and clavicles for greater inspiration. Coming back into our core section, if you notice, now we have a different layer of muscles above the TA. And let me take one layer off. This is a TA. We add one layer up, and then now we are into our external obliques. Notice the fibers are running diagonally from the center of the body. So the external obliques rather, they direct diagonally downward immediately towards the linea alba. Linea alba is this the center. It's a thick fibrous band that extends from the xiphoid process to the pubic symphysis. And so they have attachments to the lower 8 ribs, the iliac crest, and the linea alba, and they can be seen on extensions of the lateral intercostals found in the external surface of the ribs. And when they contract, they aid in inhalation. Contracting the external obliques bilaterally will produce flexion of the lower spine. In unilateral contraction will produce lateral flexion and rotation to the opposite side, as in standing twists. Let's add one more layer of muscle to our core. Notice how many muscles we are we're adding here. The rectus abdominis, and they usually, this is what the six-pack, right? This is what we think as healthy. Due to the superficial nature of the fibrous band separating the bellies of this muscle, they have a unique and well-known appearance. And usually in a well-defined individual, you may be able to observe an 8-pack because the linea alba and 4 horizontal fibrous bands create 8 bellies of the muscle. And these 2 parallel muscles run vertically from the pubic crest to the xiphoid process and the cartilage of the 5th, 6th, and 7th ribs. And contraction will provide flexion of the spine. Internal obliques. And these muscles direct diagonally upward and medially toward the linea alba, and they attach to the fascia of the lower spine. Iliac crest and inguinal ligament, lower ribs, and the linea alba. The internal obliques can be seen as extensions of the internal intercostals, muscles of the internal side of the ribs, and which, when contracted, aid in the act of exhalation. When we contract the internal obliques bilaterally, we find flexion of the lower spine, and contraction unilaterally will produce lateral flexion or rotation to the same side.